which is the most common pediatric emergency, I would have answered myself dehydration, or I would have said febrile seizure, or I would have probably gone a little ahead and thought of school going kids and said about acute gastroenteritis. What I am now worried is about the mental health, isn't it? Young, small boys, adolescents ingesting toxic substances, being aggressive, getting themselves hurt, hurting others, uncontrolled behaviors in school, beating their friends, or get bullying their juniors, bullying to an extent that the junior tries to harm himself or dies on spot. Isn't it what we are reading every day on WhatsApp? Almost every day now, when new batches have started everywhere, there might be a case which you have missed. So it is a rule out. Twist score is a rule out score. It is not a rule in score. So we should do a Doppler ultrasound. We should do a Doppler ultrasound, and the Doppler ultrasound, as you can see, can show you a whirlpool uh, because of the twist of the spermatic cord, can show whirlpool sign. You can see that happening in on the screen.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your liked videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
I chose it because we have done some common medical emergencies. We have navigated some common surgical emergencies. So I thought, why should pediatric and obstetric stay behind? I do not have a good throat. I must be croaking in front of you. Please bear with me. I'll this time promise I'll finish it fast and we will be taking more questions. Now, please, friends, whenever I talk with an emergency perspective only. I do not talk on. I am not a pediatrician. I am not an obstetrician, but with my training, I can deal with pediatric emergencies and obstetric emergencies. So sometimes your questions take me to core subject and I really falter there. So if it is something to do with emergent issue, I would love to take that question and answer you back. And I request you all to please keep putting your views on that particular subject, so that we can, have an later on have an idea what can we do further better to improve the management of these emergencies. So let's start. And I have, on a start only, I have a question. And I know that if I would have asked myself as a postgraduate when I was, or even as an early faculty, which is the most common pediatric emergency, I would have answered myself dehydration, or I would have said febrile seizure, or I would have probably gone a little ahead and thought of school going kids and said about acute gastroenteritis. Anyone else has any other answer? Anyone else feels that in the present date, which is the most common pediatric emergency which worries you? Just take a pause here to understand if I can even get one answer in the chat box. Yeah. So that's what now we are still worried of that same old. I do agree with those who have posted, and thank you. Fever and obstructions and all. What I am now worried is about the mental health, isn't it? Young, small boys, adolescents ingesting toxic substances, being aggressive, getting themselves hurt, hurting others, uncontrolled behaviors in school, beating their friends, or get bullying their juniors, bullying to an extent that the junior tries to harm himself or dies on spot. Isn't it what we are reading every day on WhatsApp? Almost every day now, when new batches have started everywhere. So this is very, very important. I do agree with Dr. Natasha, correct? I would also be very worried if it is a foreign body, especially the obstructive one and even the non-obstructive one. So I would today talk about. I'll definitely discuss in short what Dr. Natasha has said, because I know she's a very passionate emergency physician. But here today I'll try to discuss what can we do if we are encountering an aggressive child in our emergency. We have to definitely rule out some important points, and those points are whether it is secondary to some trauma. Is he hurt? That is why he is behaving in some manner. Is he in pain? Has he ingested something, especially alcohol, first time alcohol intake, or for any other cocaine or any other drugs? You know, there are a lot of drugs which are now available in parties, and many of the school kids also arrange these attend these parties. At the one exam is over and then you are out for parties, and it is no longer that it is not involving those who are very studious. It is everyone who wants to enjoy. So that culture is like this, I think so. And also we have to find out whether he was suffering with some disease, especially respiratory or hemodynamic instability, before he presents to us in a aggressive and agitated state. And why I am saying so? Because I know that those who are hypercarbic, they are agitated. CO2 causes agitation. Those who are hypoxic are uh, poor in their concentration, poor in their um, consciousness. But those who are hypercarbic are agitated. So it might be that I'm dealing with some patient with a respiratory disorder. Same is with hemodynamics for blood pressures. So am I dealing with an hypertensive emergency wherein the child is having the first time feature. He's having let's say a renal glomerulonephritis, and the blood pressures are very high. So am I dealing with that? Am I seeing this patient for the first time and thinking that this is his behavior issue, and forgetting all those diseases which have neuropsychiatric manifestations? The list is very long. You all have to first understand that before labeling a child to have aggressive or agitated behavior, all those medical problems, especially the endocrine problems regarding thyroid, regarding adrenal, should be ruled out before you um start calling the psychiatrist in. Now, here there is one pearl of wisdom, and that is our job in emergency is not to make a diagnosis. Our job is to control this child and ensure that we have not overseen autoimmune encephalitis, or we have not overseen any cerebral malaria. We have not left any patient who was seizing because of a focal lesion in the brain and just saw his behavior, which was aggressive, and treated that. So, that is what our job is. There is some critical information at this point of time which I want to share with you. If this is a mild to moderate agitation, wherein the parents or a proper caregiver who has been taught, that is why every ED or every person should know how to, should have a social officer, the one who is trained in communication. That is why communication is very important, so that if possible verbal de-escalation is done. Well, I'll come to that verbal de-escalation. There are challenges which will to put a intravenous line in these patients. So that means that we need to be very clear about which drug we can use orally or which drug we can use intravenously, intramuscularly before we get an intravenous line. We should also know the difference between putting uh, the physical restraints versus physical control. Physical restraints are 4-point restraints where we tie the uh, the patient both arms and both legs. Well, this is legally not very found to be very correct, and therefore it is better to have a physical control for, let's say, 5 minutes with 5 people holding the child, so that an IV line is put in for giving an intravenous drug, especially when the child is severely agitated and you do not have that time when oral and intramuscular drug can work. Chemical deficiency is all about the drugs which we will be discussing. Why is it so unique a problem? Because I have safety concerns of the provider. There have been a lot of reports that uh, the nanny or the lady who works at home was poisoned or harmed by children of age 11 or 12 because they do not want to do their homework. So I have the safety concern of the provider. Then when they come to RED, the provider means the healthcare workers are working around this child, as well as safety concerns for this child itself. It may you leave him and he just takes that IV cannula and or a needle and puts it in his eye or puts down his throat. You never know. So we had uh, one of our PS when I used to work in anesthesia department. Her son was brought agitated, little obese child, 11 years old. And while we were trying to talk to him, and I was telling her that what it's okay now, if he has not got good marks, why are you so worried? You can get it next year. Had kept her purse on the bed and she was talking to me, and this boy opens the purse and takes out a 1 rupee coin and swallows it in front of us. We could not do anything. He just swallowed, and he was 9 years old at that time. So that is very important, that the safety concerns are very important. Please make sure that the room where you treat them, you should be, it should not have anything which they can hurt themselves with or hurt you with it. Now, EDs are, or offices are, or even pediatric EDs are, cannot have be for one person on one child. So that means that we have to be more vigilant. Instead of removing everything, it is our vigilance to ensure that nothing around it can be used in a particular manner which I have just said. Collateral information is very important. Why? Because abuse potential is there. It can be trafficking as well. We don't know. I don't know if the child is coming from. We get a lot of children. I don't know whether you get it. We get a lot of children from residential schools, and there was a child who came from residential school, and that child we presented also in one of the conference with a penetrating injury or with a knife on the near just below the scapula, left scapula. Okay, now the point is, who did that? Is this two boys fighting? Where did they get that knife? A knife which is a kufri knife, and that too in a state like Telangana. Normally, such knives are not here. So these are things that means there is a potential for abuse, maybe some elder person senior, or there is a potential for fights, and sometimes to keep their children safe, parents can give other informations. Like they can say, with the information which we got first was that he fell backward. He was walking up the state, and below there was something, and he fell on it. So such sort of informations can also be given. You have to always screen these children, whether whatever they have done or why they are behaving like this. Is it safe to send them or retain them? See, we do not in India yet have involuntary hold, but I'm sure if you are thinking that I would not be able to send this adolescent boy home, he may go and commit suicide. And I'm not going into that psychiatric chapter of how to assess the suicidal tendency, but I'm just thinking of that IPC, or now it is Bharatiya Nyaya Parishad, BNP, wherein it gives me the authority to involuntarily hold the child for his safety up to from 7 days to 30 days in the hospital, obviously not in the ED, initial 48 hours in the ED, get a psychiatric referral done, because that is very important. That is what will save him and also save me at the later point of time. I will not give you one drug to bring down the agitation, because there is no one drug treatment. Okay, consensus is not there. Someone finds typical antipsychotics good, other person may find atypical antipsychotics good. So we have to be very careful what we are choosing. So from here, let us take two cases. See, there is a difference between the two cases, and when you will read with me, you will understand what is the difference. One is a 14-year adolescent, aggressive, vegetated, assaulted the teacher at the school for what God know what reasons, and the school sent him to the ED. And he is getting further irritated when we are telling that we have to take blood samples and we have to look into you and you will be in the hospital and your parents are coming and school principal is shouting on him on the top of it. So it's a total mess. Whereas there is another same age group of autistic adolescent. So there is a comorbidity. They are already on a have a neurological neuropsychiatric illness, or I should say neurological illness. So with this, he is brought in with constant agitation and aggression. He is adult size. He is not redirectable, whatever you are trying to say, and he's trying to fight with the staff. Now, what happened is this child has undergone and was throwing seizures. He was supposed to undergo an EEG, and he was given some sedative drug in the morning hours. And now that sedative drug is losing, and he's confused. And because of his autism, being a special child, the parents did not want to stay at home in the night, and they were told, "Come to the EED. At least he'll be stable and no issues will be there." So these are the difference in these two scenarios is one is a special child, and that special child will definitely have someone in his home who can verbally de escalate him. He will know what he loves, how his mood can be changed, what are the things which he likes, and he can talk on that and de escalate him. Whereas this particular, the boy on who is case one, has never shown this to in front of any other parent, and so all those histories, whether he is hurt, whether he is in pain, whether he has ingested something, or whether this is he has a risk factor, has to be found out. So here I will first read out to you what are the risk factors you should find out. So, as yes, personal history of any mental disorders, recent hospitalizations for the same condition, substance abuse, any physical abuse, any sexual abuse. History is not very forthcoming, but then there are signs. You know, signs of cigar burns, cigarette burns, signs of having multiple bruises at of different color. That means of different age. These all are, and the um, and it is almost like this, that those who commit the crime, they bring the child, because they are very worried that if someone else take, the child may blurt out something. So they only bring the child, and they will never leave the child alone to you to talk. So these are some of the ways you can find out. You should ask the child or the parent if there is some adverse life event. So another experience which I tell you, is my daughter's, when she was in school, unfortunately, her classmate mother, who was a teacher, so the teacher was coming by her scooty, whereas the girl was in the school bus, and had an accident, and there was a death on road, okay, on the spot. That girl became hysterical. Obviously, she's sitting in the bus, and and then it took us so much time. She was brought in the emergency department. It took us so much time to get her understand and talk to her, reach out to her. So adverse life events are very important. Impulsiveness, bulimia, chronic diseases and disabilities, social isolation. Now, when social isolation, you can think of in case two. Case two, child, autistic children with special needs, they will definitely, no matter how much the parents will uh, keep them special. The teachers, their schools will help them. They will always be isolated socially, and they will feel in themselves that there is something wrong. And you never know when the mental bomb blasts. And then, this last and not the least, there can be a time where, in adolescence, when they realize that they have different sexual identity. They may realize that they are transgender or lesbian or gay or whatever all these stuff is there, and that is when they may suddenly come to the EDs with lot of aggression and um, uh, this agitated behavior. So how is the workflow supposed to happen? I have already talked about safety. Confidentiality is very important, very very important. This young boy should understand that whatever you are telling, you would remain with you. Yes, there are certain points which will go to the parents, especially when the child is a girl is less than 18 years of age. It has to go to the parents, because medical legally you cannot suppress that information from the parents. But in most of the majority of the cases, the boy, if he's grown up, he should have that confidence that what he's telling you will remain with you. I've already talked about risk factors list. You can just tick mark on that. You have to be very vigilant to identify child abuse, and that also I have discussed. And you have to intercept the vital signs. So if there is a blood pressures are high, okay, I'm dealing with hypertensive emergency. If the child is having fever, oh, this can be an autoimmune encephalitis or some infectious process, meningitis and all, or a drug overdose. And it is not that this is just an aggressive behavior. He's having tachycardia, well, infection, dehydration are a few of the differentials. And if he's having bradycardia, then a eating disorder, bulimia nervosa, is also seen. The skin speaks. When you see such children, they will have a dehydrated skin, or they may have certain sign. And I just want, if anyone can identify those on the knuckles of this child, on the knuckles of this particular child, if anyone can identify that there are ulcers, and that is what is one of a beautiful sign, which is called as, anyone has any idea of this sign? Knuckles has ulcers. So every time the girl eats, she goes to and pukes it out, because she's so much um, she wants to stay slim, zero figure, and all that stuff. So she pukes every time, and so she has, yes, thank you, it is bulimia nervosa, but the sign has a name. This particular sign has a name, which I will tell you later. I just want people to probably look into it, try to remember that this is the sign where There are reddish ulcers on the knuckles because she's putting her hand inside her mouth to induce vomiting, and she gags her when she gags, she clenches her teeth and bites on her knuckles. Okay. Now, how do I treat? How do I verbally de escalate? And what is my pharmacological help in severe cases? So, let me first start with oral drugs for mild to moderate. So, oral drugs are uh, one very good is Benadryl. Okay. And you can give a one time dose of 1 milligram per kg per each time. You can, in that dose, should be at least 50 milligrams diphenhydramine, and you can add another dose in 24 hours. For a child, no more than that, two doses. A typical antipsychotic like haloperidol, 0.025 to 0.075 milligram per kg per dose. It is weight dependent. I mean to say, if the weight is less than 40 kgs, you can go up to 6 milligrams. If the weight is more than 40 kg, you can go up to 12 milligrams in a day. We do 5 and 10 because that is how it is available. Lorazepam, which is a benzodiazepine, is a beautiful drug again. 0.05 to 2.1 milligram per kg each time dose. In one time, no more than 2 milligrams. You can repeat it every 6 to 8 hourly. It is age dependent. Age dependent means at 12 years less, 12 years more. If less than 12 years, no more than 4 milligrams. If in a day, if more than 12 years, no more than 8 milligrams in a day. The newer one is olanzapine. Olanzapine is available in oral form. I do not think, correct me if I'm wrong, that injectable form is in India or not. We use olanzapine a lot, where we give, but we ensure that we don't give it within 1 hour of benzodiazepine. They both work together, cause a lot of depressions, because as you can understand, GABA, both of them have this GABA role on receptors. Um, we can give as much to initial studies said that give it if the age of the child is 13 years. Present literature has been updated which says that you can give to as young as 4 years of age. The weight, it is weight dependent. That means you can give to if the child is less than 50 kgs, the dose is 0.25, and if it is more, then you can double the dose. It is 50 kgs is normally the weight which you are looking for in a for a child. It doesn't go beyond it up till until the child is very over obese. Apart from that, IM doses which can be done to when the child does not have an IV is doses are same what we have mentioned above, but you have to, if you, and you can repeat haloperidol, which is a typical antipsychotic, within 20 to 30 minutes, so you need not worry about it. Olanzapine has histaminergic, muscarinic, adrenergic, all roles are there, I was just telling. Whereas with haloperidol, the worry is always about tardive dyskinesias, patient having akathisias and dystonias. Well, to correct that, oral Benadryl can be given one time, but do not be in a habit to prescribe that and send the child home. Why? Because no matter whichever antipsychotic you are using, QTC prolongation is seen. Corrected QT interval on ECG, which can lead to cardiac arrest at home. And this also has been in news and for various cough syrups in not so recent past. So be very careful. Apart from respiratory depression, they also cause QT prolongation, and therefore you need to be very careful while sending them home. Now, what we can use which does not have IM or not does not need IV but can be given with simple intranasal atomizer. I do not subscribe to brands, but this is the only one which we have, so kept the photograph of this. is midazolam, benzodiazepine. Midazolam is 0.4 milligram per kg. Intramuscularly, we give it as zero point 0.1 milligram per kg, whereas intravenously, at one point of time, we give 0.05 milligram per kg. So we have to be very cautious about it. So, uh, Mm. see, there is. I'm putting a lot of stress on these patients who are coming with mental aggressiveness because these are not the regular emergencies which we manage, and we don't. We are not here to make a psychiatric diagnosis. We are just here to calm them so that we can further work on them. Now, let me tell you what are the investigations you can send. You can send a CBC, complete metabolic profile. We are especially looking for hypomagnesemia and hypophosphatemia, which happens with bulimia nervosa, eating disorders, and therefore we should evaluate the child for urine analysis. We just said infections can cause, and urine infections are very common. ECG, I've told you that we should have an baseline ECG because we would be using antipsychotics, and if there is a QT prolongation, it has to be matched to the previous ECG. We discussed the fact that endocrine disorders are important cause of this aggressiveness, and so thyroid profile and adrenal cortisol levels should be done. Young girls, urine pregnancy test definitely. I'm not a very big proponent of urine tox screens because there are a lot of false positives and false negatives, but still going ahead and doing it. Serum alcohol levels, if it is available, blood alcohol levels, if it is available with us, or how do the police officers do scan the public. That breath analyzer can also be used to document. Again, there are pitfalls of using all these things, especially when when a child has been consuming or adolescent has been consuming for a long time. He will not test positive. Serum tox screen for certain toxicity profiles can be done. Lumbar punctures, CT head, and doing for looking for sexually transmitted illnesses, infections is on the last part of this verge, which can be done to especially for those kids which where you are suspecting a lot of trafficking or abuse. This is the most important slide of that whole thing. How do you verbally disengage? See, I've written something in short, small, whereas, but there is something important is learn, listen, and empathize. Okay, you should remain engaged. Do not take that anger of that person personally. And this we do, isn't it? The patient is shouting, and we think that he is blaming me only. I am the doctor, I am being blamed. Sometimes it is not that he is upset with. Establish, yes, we do establish limits of unexpectable behavior. We do reinforce positive behavior, but we should not take their anger personally. And obviously you should remove those triggers which can cause escalation. For example, the child is not happy with his sibling. There's no need for the sibling to be in the room, and this we will come to know by this time. You have to clearly introduce yourself. With a child, you cannot just go and just check his blood pressures and all. He will feel much more worried and will behave further badly with in front of you. So language should be simple, movement should be slow, as well as voice should be soft, because we are dealing with people with a generation which is called a Z or whatever generation you call, and this generation does not take anything easily. They do not have perseverance and patience to understand things. So we have to go to their level to make them understand. Rest all, you can understand that there are certain people in their life whom they will listen to, and it is always better to keep them with you. There are certain available consultants, be it your psychiatric consultants, be it your security guard, who should be there when you are doing a verbal de escalation, especially in severe cases, though it may not work and you may need drugs. I've already given you the list of my typical, atypical antipsychotics. Apart from that, I'm giving you an anesthetic drug, which is ketamine. Now, those of you who have used ketamine in anesthesia or in procedural sedations do understand that it causes sort of a dissociation. It is a dissociative drug. So everyone starts feeling better, has good dreams, and they are on a little high after doing taking ketamine. Especially a dose of zero point 0.5 to 1 milligram slow IV and a 5 milligram per kg or a 4 to 5 milligram per kg intramuscular dose can be used, but we have to follow the guidelines of procedural sedation after this. We have to monitor the blood pressures. The child has to remain on a continuous cardiac monitor. We have to make sure that till the child is not out of ketamine effect, he should not be discharged from the ED. The data is still lacking in pediatric population. How to use ketamine in pediatric aggressive behavior, but it is so quick to it is much more quicker than midazolam, it is much more quicker than haloperidol, and therefore it is slowly becoming the drug of choice across various EDs. It does not have a potential of abuse if used for one time, but then we have to be very, very careful because we are using a drug and have to keep the parents informed about shared decision making about use of this drug. It does not affect the respiratory rate. It may increase the blood pressures a little, so we have to be careful if the child is already tachycardic and hypertensive. So this, friends, to me, from me is to you, is how to manage a pediatric aggressive behavior. Well, I will take some questions at the end and discuss with you how would you manage a case. Is it just haloperidol or is it any other drug which is being used? There's something else which we often see a lot: urgent issues in kids, and these are testicular torsions, paraphimosis or phimosis, and a zipper at causing skin entrapment. Well, these are not so difficult emergencies, yet they are time sensitive. They may cause a lot of issues if not treated the right way. So, give me time to just introduce the first one to you. When the child is small, he may not give you any history. This just it could be fussy, limping, vomiting continuously. Nausea and vomiting has a very high likelihood to be a testicular torsion. Okay, so it is my experience that the most crucial step which I would take is to do a examination. School going children, they'll be a little embarrassed. They will not understand that if they are having pain down there, should they tell or should they just hold on? They may tell headache, they may take paracetamol, and they may go beyond the time when things can be saved. Means arterial Doppler is still good. They may cross that 4 hours time. So that is why atypical symptoms, atypical presentation, and they may require, even they will be in such a severe pain that fentanyl and midazolam will be required. Okay, so this is this child, 14 years old, acute severe unilateral testicular pain radiating into his abdomen, lots of nausea and vomiting, and he was playing football just before it in his school. But when asked, he denies trauma. And when you examine him, obviously, when someone says pain abdomen, and thankfully this child has means on his right left side, but if some child comes to me with pain abdomen, my first differential is appendicitis, and I'm sure the same would be yours. But this child, any child for boy who comes with pain abdomen, your examination is not complete till you do not see, examine the external genitalia, because it's a time sensitive emergency, and he will lose a testicle if you have not done. Emergency physician or the first doctor of contact has not done his job. Well, high riding left testis was seen. It was moderately swollen and very tender and very painful on palpation. And I'm sure all of you understand what is cremastric reflex. When the middle of the medial part of the thigh is shaken, then that side testicle would rise up, and that was absent. Well, with uh, okay, oh, I'm so sorry. Okay, so how do we go ahead? We look out for age. It is bimodal. It is there with very small children as well. It is very much possible in the middle age group as well. A lot of comorbidities are possible. So if is congenital, there is a issue with vas difference, or congenitally there was some testicular abnormality, or some syndromic child would also have this. Circumcision status is also very important. Acuity of symptoms. So if it is pain happening over gradually increasing over a period of time, I would think more of epididymitis, but along with fever and nausea. But if it is sudden onset severe pain, it would always be testicular um, testicular torsion for me. Fever, dysuria, and discharge. Yes, urethritis can also one of this. Nausea, vomiting, more likelihood to be testicular issue. And there can be some precipitating uh, illnesses, minor trauma and viral illnesses, which can cause this torsion. Also, running in extremes of exercises can also cause torsion. So this young chap, suddenly new year promises, I would be going to gym every day, and starts lifting weights suddenly and lands up in testicular torsion. So be very careful of these situations. That extremes of exercise can also cause an abdominal pain. Be careful, and if this history is achieved, you have to inspect, where you need to see for discoloration, lesions, and trauma scars. You have to see for the testicular lie. Transverse lie is equal to torsion, whereas the normal lie is either oblique or straight. I mean to say, uh, normal is abnormal is transverse. It would be whether the tenderness is diffuse and focal, unilateral or bilateral. That also makes you understand whether it is testicular torsion, or whether it is a simple, not a simple, but a epididymitis or an appendigeal infection, other infections. But there are pitfalls to it. Is high riding testicle a 100% pointer towards testicular torsion? No. 50% of times it is not there. Is cremastic reflex always absent? No. In 33% it is normal. So that means 50, 30 to 50% of times, if we do not keep a high level of suspicion, do not further send the child for an ultrasound, do not cause a surgeon to take a look on the child, we may lose to diagnose this patient. Therefore, high index of suspicion, and especially there is a score called as twist score. T stands for testicular swelling with 2 marks, W wooden hard testicle for 2 marks, and nausea and vomiting, high riding testicle, and absent cremastic reflex is all three are 1 marker each. It is a rule out score. If there is something which is 0 to 2, you can rule out with 96% of surety. But again, 4% there might be a case which you have missed. So it is a rule out. Twist score is a rule out score. It is not a rule in score. So we should do a Doppler ultrasound. We should do a Doppler ultrasound, And the Doppler ultrasound, as you can see, can show you a whirlpool, uh, because of the twist of the spermatic cord, can show whirlpool sign. You can see that happening in on the screen. Okay, the twist is easily visible. Same time, there would be a lot of edema, there would be an absent venous flow, definitely, but the arterial flow initially would be preserved, which will be lost over next 6 to 8 hours. So this is very important, that, as I've already said, surgical consult is very important. And how do you, um, what do you do? Oh, I don't know how to do. No, no, this, see, this is time sensitive. If you send him from your clinic to a big hospital, and this child, you have given him analgesia, you have diagnosed. But if you are waiting for him to reach there, he may lose the testicles. So, therefore, these are skills which every doctor, every MBBS doctor, any doctor should have. Better for a surgeon because that is his training. But all emergency doctors who deal with emergencies should know how to do detorsion manually, which is 1 to 3 times like opening a book, medial to lateral. And this will relieve the pain. And you can also do ultrasound guided as well. You can take help from your radiologist friend. It does not give you time to wait for surgical expertise to come in case he or the surgeon is not available on the floor. Well, I just thought it is better to discuss paraphimosis also. Now, when does it happen? In children, you will think, friends, that today I am trying to discuss more of these emergencies, but these are more common. So, what happens is a child comes with head injury. You start mannitol, um, because his head injury is severe, and then you put a um, uh, Foley's catheter, because that is the action of mannitol. That is how mannitol would be taken. But what you forget is to um, bring back the foreskin over the glands, and it remains retracted. And next day morning, the heart rates, now child is is head injured child, severe head, let's say moderate to severe. He will not complain pain, but what will happen? The heart rates are going very high, 170, and you are thinking, what is happening to this child? Okay. And then you don't know. And then when the bedding is done, and what you are doing is you are telling sister, let's paralyze this child, he's not doing good on ventilator and all. You have not seen that someone who has put a Foley's, what has that person done? And then comes this issue of having a paraphimosis. Very, very important. That is why learning should start from very basic. Please learn how to, and this is not only for kids, because this particular talk is about pediatric emergency. That is why I am saying even elderly patients, head injured patients, those who are lying on ventilator, please do take a time to make sure that whatever intervention you have done has not harmed. Do no harm is very important. Correct. Now what do? you you have to decrease this edema so that you can bring back the skin over it. And you have to be as gentle as possible. There is something called as dorsal penile nerve block. Well, if you ask me, is it a very difficult block? No. But still, those who are anesthesiologists, those who understand, it is very simple a block. It is nothing to do. You take lignocaine, 2 cc each, 10 o'clock position, 2 o'clock position, and then you go past the skin. And as you can, if you can zoom in the diagram, you can understand where you are giving. It will make it a little easy. Okay. But how to decrease the edema? What you need is all the possible glucose. So I went through all the studies, and I realized people have used gauzes soaked in 50% glucose, gauzes soaked in 20% mannitol, gauzes soaked in normal sugar sachets also, dissolved in water, obviously, because such gauzes, when wrapped around the penile part, will decrease the edema because of their osmotic nature. And within minutes, few minutes, you can do the procedure and make the child keep the child pain free with some IV analgesic as well as a dorsal penile nerve block. It is very important. It is again time sensitive emergency. You don't do it and you wait for surgeon to come and then do it, because or urologist to come and then do it. I don't know what will happen. So prevention, so definitely is an important step. Prevent it. But if by reason someone's mistake it has happened, you should know how to do it. A lot of Google videos are there. I'm sorry I have not been able to put a video here because I think so this doesn't support a video. But I would request you to check out how to do it, because this is a skill of a doctor, of a healthcare worker. It is nothing to do with which department I and you have done post graduation in. Okay, I'll move forward. And if you can see this slide, it's a very jam packed slide. I put all the four slides in one, and this is a very common problem, getting the skin entrapped in a zipper for a small kid. And this I saw on a flight some 6 7 months back. I was flying, and this mother, she's busy in something, and this child is having pain. And believe me, because it was an international Emirates flight, they knew how to work. I don't know whether our flight attendants would be as trained as them. There was a doctor on the flight who just took these two things. You can see a plier plus and something which you use it to tester or something like this. And he engaged it flat by holding with the plier. The anterior part of the zip. He engaged the flat head of that and just twisted it and took off the total this lock. And the moment the lock was off, obviously the zip opens. And what that mother was doing was she was trying to pull it, and the cry boy was howling in pain, obviously. And so much, uh, n- uh, so much trauma which happens. So be very careful. Again, it does not, if we would have thought that once we land in Dubai and then we think of getting this child sent to the hospital, think of how much pain he would have been and what all trauma it could have caused him, है ना, for a very silly mistake. So these emergencies are not, again, I'm saying, specific to which department you have done or not done post graduation. These are those emergencies which you should know how to deal with. And sorry, friends, this time I've not talked on fever and seizures because I've already talked about them previously. And I know that they can be talked by in future as well. I have just one I'm just won this ultrasound, and I'm sure now you will be able to recognize what is this ultrasound about. Can you please, can anyone please help me to understand what is this ultrasound about for a child who has come with abdominal pain, and he was for six or something, 6 years old, severe abdominal pain, howling child. Any idea? Any guesses? Already reaching. No, no, there is. We are not seeing intestinal loops at all. What we are seeing in is torsion. Good, Natasha. Thank you so much. Because as you can see, I put Doppler over there. The one side is good flow, other side flow is not there. Rather, there is an heterogeneous mass that is all coil of spermatic cord. So please remember, your examination is not complete for abdominal pain if you have not seen external genitalia. people over here should also remember hernial sites are also as important. If you don't talk of hernial sites, you are losing the diagnosis of hernias which have been strangulated, and that can cause such a problem, big mess. So, see, what happens is that all of us have now quite adapt to understand a lot of things like um, hypotensive young lady, oh, she may be having pregnancy, ectopic rupture. Ectopic comes so easily to us. Postpartum hemorrhage also comes easily to us as a diagnosis. But what we forget is if a young lady is coming with a pre-viable pregnancy, there can be a septic miscarriage. And see, in maybe not in tertiary hospitals, I do not get septic miscarriages coming to me, but in small EDs, in a country where abortion is illegal after time time where still we are struggling with our laws. There are a lot of people who are untrained, unlicensed practitioners out there where who are doing it these uh, abortions in the worst possible ways, and these ladies are coming to different EDs in full blown sepsis with the septic miscarriages. Obviously, yes, 22 weeks of pregnancy versus 24 weeks of pregnancy of miscarriage, you have to understand septic miscarriage means 22 weeks. Okay, so this miscarriage up to 24 weeks, isn't it? So this is very important different diagnosis. Why it is important is about this young lady. 72 hours after going an elective surgical abortion, she doesn't want to tell anybody. She doesn't even want to tell her doctor. She presents with fever, pelvic pain, severe refractory hypotension, and she's very ill. And we are thinking of, oh my God, she might have an ulcer, duodenal ulcer, which has ruptured, or an enteric which has ruptured, and she's having peritonitis. Little we are thinking of, go and, oh my God, she's young. She's not having all this because of it. Let's do a pelvic examination. Put a hand on your heart and tell me how many times when young females come to your emergencies or your place, you and come with fever and pelvic pain, lower abdomen. Pelvic pain is abdominal pain, isn't it? And hypotension, you do a pelvic examination. Not much. Believe me, not much. Because we are so focused on recognizing sepsis and starting sepsis treatment. That is more important than just doing a simple. And the problem is that the patient has not told us. Patient doesn't tell us that she has undergone it's a abortion because she doesn't want to. She wants to hide it from many people. And when once, as she was down and very sick, UPT was done, which obviously, if we would have missed doing UPT, we would have probably missed the diagnosis also. So that is the importance of UPT, a pregnancy test. We saw a foul smelling discharge, which she kept on telling us that she was suffering with this vaginitis and all. But thankfully, the cervical discharge, and later on her sister coming in, and there was some other issues also happening, and we could catch the diagnosis. But yes, the differentials at the first time were complicated UTI, appendicitis, pelvic inflammatory diseases, and also if she would have come after delivering a child which she was not, she was unmarried, it could have been a postpartum endometritis. My friends, my suggestion and request to every one of you is to have a very high suspicion when you are doing all these. These are very common emergencies. They might have not been, they are not arresting, but that doesn't mean that someone who is not in cardiac arrest is not in emergency, isn't it? We did all that what everyone does. We did CBC, we did lactates, we did cultures, we sent for blood because we thought she's in some sort of septic shock or hypovolemic shock. We are just working on all that. And then we went and did a beta SCG levels as well. And in those patients who are stable, you can send them to, every day. It happens every day with you and me. If the patient is stable, send to ultrasound room, and they could have checked the retained products of conception. But then, even if there is no retained product seen, still there is a possibility of septic abortion. So this you have to understand. When gynecologist turned in, she also took some cultures from cervical fluid, because that would guide her to antibiotic therapy. So obstetrician referral helped us. You have to remove the source, as you do in any septic case. That is a repeat DNC, definitely sepsis management of fluid resuscitation, 20 to 30 ml per kg, broad spectrum antibiotics, sending a venous blood gas and knowing the lactates, supporting the ABCs of the patient, all of them, and taking blood cultures, all of them are important, as, as important as this. Just a recent study which I was published, which said that though we are in an era where nothing works except for piptaz, imipenems, meropenems, vancomycin. But this study, not coming from India, obviously, coming from Europe, says that ampicillin, gentamicin, and metronidazole, for obviously for anaerobic cover, may provide a better empiric coverage. However, I would still say whatever antibiotics are being used in your place, please stick to that, because this antibiotic stewardship is an entirely different topic. I have a slide on PALS and obstetric, but instead of telling you from slides, I'll just verbally tell you that how do you manage if there is a child who coming back. This is cardiac arrest. Uh, if the baby has arrested in front of your eyes, you were on rounds, he he had a cardiac arrest, or a heart rate below 60, or is gasping in front of you. You were there when he was fine. You are there at the same time when he has gone down. It is okay to run and get an AED machine or a defibrillator, whatever is available. But if it is unwitnessed, he's brought, his heart rate is 60, he's gasping, he's brought and he is not unresponsive, obviously, then 2 minutes of CPR has to be done. Chest compressions. This is the difference between an adult and a pediatric CPR, one of the difference. There is a difference of witnessed versus unwitnessed arrest. Witnessed arrest, if you are alone, you can run if it is you have seen it happening. But if you have not seen it happening, then you should do 2 minutes and then go if you are alone. The second difference is 15 is to 2 versus 30 is to 2. The moment you get a helping hand, you should come down to 15 compressions followed by 2 rescue breaths. Rest all is same as adults, apart from the defibrillation dose which you are giving in for shockable rhythms, like ventricular fibrillation and non ventricular tachycardia without pulse, pulseless VT, we call it. So that defibrillation dose, please remember, the first shock is 2 joules per kg. The second shock is 4 joules per kg, and the subsequent joules are can be more than 4 joules per kg, but you should never go beyond 10 joules per kg in total in a child. That means if there is someone who has 20 kg, never go beyond total 200, 20 into 10, 200 joules, because then there will be myocardial problems with the myocardium. Other difference, third difference, in adult, when you give the first dose of amiodarone, you give 300 milligrams. Second dose, you give 150 milligrams, and then you start an infusion. In children, you give a 5 milligram per kg dose. You repeat 2 more doses. In total, 3 doses of 5 milligram per kg. You don't start an infusion. It is hypotensive drug. Okay, so amiodarone 3 doses of 5 milligram per kg can be given in children. Coming to lidocaine, if amiodarone is not there, you use xylocard, the cardiac lidocaine. So in that cardiac lidocaine, adult you use 1.5 milligram per kg first dose, 0.75 milligram kg second dose. Whereas in child, you use it once, and that is 1 milligram per kg. So apart from this, there is no difference. Same 5H and 5Ts. Yes, I do understand. I know that you already understand. Adults, cardiac arrest is mostly cardiac cause, has a cardiac underlying cause, whereas children, it is mostly a respiratory underlying cause. This is the only basic difference which has been highlighted in these three slides. I don't stop here. I just take one more minute. What is the problem difference between doing a CPR for an obstetric lady, a full term pregnant lady in cardiac arrest versus a lady who is not pregnant but in cardiac arrest? The difference is that fetus, which is putting the pressure on the IVC, and the peripheral pooling of blood is happening, and that is not going back to the heart. The heart is empty, so no matter how much good compressions, appropriate compressions you are doing, there is nothing which is coming out. So what you have to do is to pull the uterus, which is called as leftward displacement. There are two techniques to do that leftward displacement. If it is a trauma case, you have to put that lady on the trauma board and put her completely, because you cannot move the cervical spine. So C spine cannot be moved. So to move her in together, she should be kept on a trauma board, and the whole board, the pillow or has to be put under the hip and pulled so that the entire thing falls towards the left side. Whereas in non-trauma cases, one hand technique, two hand technique. If you are standing towards left side and you are pulling the uterus towards you, then you can use both the hands and pull the uterus. But if you are standing on the right side of the patient, then to push the uterus on the other side, one hand is enough. Now these are important points as far as AHA is concerned. Rest all is same, be it the doses, be it the drugs, be it the high quality CPR, everything stands same except for the causes which are different and the uterine compression which is taken care of. And I would not go into perimortem cesarean section, time doesn't permit me. I hope I have done justice to bring to you the simple emergencies which you can see anytime, all are time sensitive, as well as the cardiac arrest, which I could not take for a longer time. I excuse me for that. Thank you so much. And I will now take questions.
So much, ma'am, for your wonderful presentation. We do have some doubts coming in from our doctors, and we will be taking that. Going to be taking one of the early questions that we had. It's from Dr. Kulkarni, who wants to know how to manage reversion of uterus after full-term normal post-delivery status in a rural setup.
1 minute. I'll just. uh, Kulkarni sir has asked how to manage. I'm so sorry. Uh,
Reversion of uterus.
inversion of uterus after full term normal post delivery status in rural setup. So that's what I was trying to say right at start. See, what I'm worried is PPH in this case. What you are also worried is postpartum hemorrhage in such cases, and that is why one have, and we have recently seen a gynecologist also committing suicide because she was not able to take care. Well, if you ask me, they do packing of uterus, they do manual uh, re rotation of the uterus, but this is gynec work. This is nothing to do with the emergency. I've never done it, but if such patient comes to me, I can get the packing done. I will definitely use tranexaminic acid. I will definitely initiate massive blood transfusion protocol, anticipating that it would be a postpartum hemorrhage. I will call the obstetrician as soon as possible. Use of syntocinon or methergine or prostaglandin E2, I would take a shared decision making with my obstetrician. That is what I would do. Packing, yes. Trenexa, yes. And can be done in rural setup. And massive transfusion protocol, no. Getting a obstetrician, I believe she has one. That is why she is there. She has just delivered. So that's my answer, sir. If there's something else, I would love to know from you, sir.
So next question from Dr. Madhav is, complete abdominal pain assessment requires clinical examination of the genitalia, rectum, and back. Is it relevant even now?
I'm so sorry. I'm getting as. Can you just tell me the name of the so that I can check that question myself? I'm not able
Dr.
to
Madhav
see.
Kulkarni.
Okay, okay, okay. I'm so sorry. The voice is somehow. Yes, complete abdominal examination assessments. Definitely, definitely, sir. Relevant still now. See, there is no. Okay, so is do you want to say that physical examination can be now left out because we have moved to something which is CTs and MRIs and ultrasound? Well, I would say no. Physical examination, maybe I'm from that generation where talking to the patient we get the history, or physical examination I give very much importance. I do not think so that I would leave the genitalia. I did not talk of rectum. Back, I will definitely check. If it is a trauma case, I will definitely log roll. If the patient is hypotensive, I will log roll in primary survey only. If the patient is stable, I will do it at the end of secondary survey, but I will not leave the physical examination. Adjuvants like ultrasound or gold standards like CT can help me to substantiate my diagnosis, but not to replace my clinical acumen.
So the next question is from Dr. Rajendra Kumar Maheshwari. What are the absolute indications in children for a CT scan of the head, and is it done many times unnecessarily?
Thank you so much. This is a very important question, sir. So we follow now the Pecan rule, and I'm sure it is available everywhere. We do not do CTs because each time we thank you for putting this, that each time we do one CT, out of 2,000 CTs done unnecessary, one child will definitely develop leukemia as he grows up. That is what the statistics says. So it is always better to follow rules. Pecan rule is there, PECARN. One can follow those rules to put your children for put their patients for this. And I see that mostly nowadays, even neurosurgeons do not go ahead and do CT for minor and mild head injuries, obviously based on GCS and but then one has to be individualized the mechanism of injury, the GCS score, the which will definitely help us to guide. So, but yes, everyone should follow one or other. Can either Canadian CT rule or Nexus rule or Pecan. One should follow some rule and document it. Do some study where how much sensitivity and specificity they have found for every rule in their kind of patients. So this is a very important thing, sir, and I do agree with
So the next question is from Dr. Biswas. If you could explain about the open book technique of the torsion of testes.
open book is nothing but just holding out the testis and medial to lateral. So lateral to medial has happened when it has twisted. So you have open. How do I open the book? I open the book medial to lateral, isn't it? If you can see me now, this is the way you open the book, isn't it? So you are going from medial to lateral. So that is how we are going from medial to lateral to open this. 1 to 3 rounds are enough, because mostly it is seen that no more than 3 times it goes. So if it is just one time, it will open up well. Doing it under ultrasound guidance would be better. Doing it in a child with procedural sedation would be better.
So, doctors, in the interest of time, we will be taking the last two questions for tonight. So, the next one is a question from Dr. Ravindra Kulkarni, sir, and it's asking that if you can book an unwed mother patient as MLC.
uh, um, okay, 1 second, can I uh, uh, can we book a unwed mother patient as MLC? Is that the
Yes,
question?
yes, ma'am.
Okay. Sir, definitely, if the lady is less than 18 years of age, MLC has to be done. There is no other way. But now the rules are a little different. If she is less than 18, yes. If I do not know, there are a lot of other circumstances as well. Is it with consent? Is it without consent? I would say it is a very generalized statement that she is unwed and that is why I'm booking under MLC. It is not like this. It has lot of subtopics: consent, without consent, age of the patient, who is the one who has brought the patient. Sometimes the girl is not complaining, but it is the parents who are complaining. So there are a lot of there is lot of understatement to it, and I have to look into it, and I should be back with this answer. But I do not think that we are booking every unwed mother as MLC. I don't think so. It is not possible also that if we are booking every unwed mother under MLC. No, sir. But I'll find out. Three, I have told you. I'll find out what all are not under it. Thank you for giving me this question.
So, the last question for tonight is from Dr. Prachi. What are the conservative management that can be done for uterus prolapse?
Okay, same thing, Dr. Prachi. What we were doing for these other uterine deformities is prolapse again is doing what? If it is causing, if it is uterine prolapse is happening post um, delivery, then I'm worried of one thing only: PPH, PPH, PPH. So same packing and all will be done. And if this prolapse is happening at an elderly age, lot of embarrassment and all, then only you pack and send it to the obstetrician. I am not an obstetrician. I would not be there to help. But one thing I'll tell you: those people who pack should always document the time of packing. Problem occurs when packing is done but you have not documented and the patient is doctor searching for next 48 hours and lands up with severe sepsis. So these are also interventions are also critical interventions. So shared decision making and the mm, preventing the mother to die from a hemorrhagic shock is what I would focus on. My skill would be utilized in this patient to prevent her from dying from a hemorrhagic shock. That is how I think about it.
So that's it for the questions. And thank you, ma'am, for patiently taking in all our doubts from our doctors. Thank you once again for doing this session with us. It was a wonderful learning for all of us, and we hope to see you again on Netflix. Thank you once again, ma'am.
Thank you so much, and thank you, Dr. Islam, for telling the degree of prolapse and all. As I have again said, I am not a gynecologist, I am not a pediatrician, so there will be definitely difference of opinions. What is important is to keep your child and the mother safe. So that I can help you out with. Thank you, everybody. Have a good night. Good.
Thank you, ma'am.
Thank you so much.